All right, take it away, Jenny.
Thanks, Kitty. Good afternoon, everyone. Thank you for joining us today for the Values and Principles Work Group of the Universal Health Plan Governance Board. Thank you for your patience as we are starting a little bit late. We're just having a few minor technical difficulties, but it looks like the team is here. We have two group members who are not able to make it today, so this will be the full group today. And just to welcome everyone again and remind everyone that this is the Values and Principles Work Group, which was established for members of the board to come together and have deeper conversations around the values and principles that the board would like to establish for their work. As I've said in previous meetings, we will not be taking public comment during this meeting, but please feel free to submit public comment either in writing through our website or come to the general board meeting that will be held July 18th. You can provide public comment there in person or virtually. We did present to the full governance board last week in the full board meeting, and the board did give the group the thumbs up that the general principles that we've been looking at are the right direction. And the board was happy to see the work that had been done, but asked for the group to come back together and do a little bit more work in terms of defining terms and really drilling down on what we would like the principles that we've put together as overarching principles to really mean to the board. And so I'm going to hand it over to Katie to take roll call, and then we will have Warren George, our board vice chair, facilitating for us once again. So Katie, please go ahead.
Thanks, Jenny. All right, Warren George.
Here.
Wonderful. Michelle Glass.
Here.
And Chenwei Chi.
Here.
Thank you. And we do have two other members of part of the work group, Amy Fellows and Debbie Diaz, but they are both unavailable today. And I will turn it over to Warren.
Okay, thank you. Jenny and I talked a little bit, and hopefully we've set this up in a way that we can make quick work of, we want to be clear on what we prepared as 3 recommendations to the board. And Katie, if you could go next slide. Recommendation number 1 is basically the health equity statement and the language from our accompanying document that we recommend that the board fully endorse and adopt the Health Equity Committee statement, pledge to complete all board work in full support of the goals of that statement in the elimination of bias in decisions and actions and in rectifying past bias as an absolute principle of universal health care. And then the Health Equity Committee statement is below that. Do we have full support of the members on this recommendation? Michelle?
Sorry, I was giving my 5
Oh, yeah.
55 and Zoom auto recognized it.
Oh, yes. Are you in agreement, Chenwei?
Yes, I also give you my 5.
Okay. Something is different with the screen, so I can't see everyone as usual, so I might have to ask. So moving on to the second recommendation, Katie. This says recommend that the board adopt the following overarching principles as further defined by the work group report. And I'd like to skip over this a minute. This is where we have more work to do. I actually want to show there's more discussion about some other materials that were presented. Katie, can you skip down to recommendation 3 for just a second? One more. We've had some discussions in the board as far as particularly defining terms of equity and fairness, financial hardship, medical cost. And if we could just go one more, Katie. Oops, thank you. We have, I don't know how many people were able to read in detail about targeted universalism. We had not talked about that so much before, but we had talked about citizen juries as a way to gather community participation and understand adopt community values and principles for defining fairness and equity. For me, the targeted universalism is another tool to accomplish principles. It's not a principle itself. I like both of these and would like to hear from Chunwei and Michelle on whether they think this is a reasonable recommendation. We're really recommending for the board to consider these in using the community to establish fairness and methods of equity. Chunwei?
Yes, I agree. These two approaches are the appropriate approach for the board to consider.
Michelle?
I agree with the caveat that I think our overarching health equity statement would guide the citizen juries. So wanting some parameters, right, to make sure that, which I don't anticipate happening, but it's possible that the majority could choose to not value the needs of the minority in some way. So I think that as long as that is a foundational or framework that the citizen juries would be operating within, I think these are very complementary processes. And I actually, on page, what page is this? Page 39 of the universal or targeted universalism article actually talks about a process integrating full participation from the beginning, from everyone who would be impacted by, whatever system. So I think these are really aligned ways of defining and implementing our values and principles.
Okay, thank you. And I have the agreement. I did read the document, and I have agreement that they are compatible. And this will be a little bit a matter of actually communications and community engagement in my vision of how to use these principles. I'm pleased that we have talked about them in our offering to the board, and I'm anxious to see what the other committees can do with this. Okay, I see nodding. So now, if Katie, do you have access to the full document?
Yep, I will pull that up now. It'll be just a moment. My computer decided to pause.
Okay, thank you. And I can finally see people, so I don't know what happened, but that. While we're doing that, I want to thank, as always, members of the public who are listening in, and really appreciate the interest and support.
I'll just have to share my screen. It won't let me pull it up.
Hmm.
Okay, there we go. Almost. Can you see it okay?
Yes.
Okay.
If you could make it bigger.
Yep.
So looking down at the four overarching principles, we did collect some board comments, both from the meeting and provided by Debbie, who's not wasn't able to attend today. And I think we did have a little question of whether we have arrived at the correct language for minimizing individual financial hardship from medical bills. And I can't get both screens up at the same time. I believe that we've agreed on the language of minimize financial hardship from medical costs on individuals and families. Do we have agreement on that?
Yes.
Okay.
Yes.
Okay. Now we collected a number of comments. If we can that's good enough, on maximizing health. And the word fulfillment, I think, is confusing to people until we kind of provide further definition. Does anyone have a better word? I think it all makes sense when you talk about it and read the explanatory statement. Whether it would be opportunity for individual fulfillment, or do we have anybody have a different word?
To me, when for our discussion, my understanding or interpretation was that we were talking about a combination of the concepts of agency within healthcare and also satisfaction with healthcare. And I know that word is here in the paragraph, but those are the two closest words that come to mind for me. Is that similar to how other board members are viewing this? And if that's the case, is the simplest and most straightforward thing to do to include both words, to say individual agency within healthcare decisions and satisfaction with their healthcare?
And how would you define the word agency? Just be clear.
Yeah, so agency, like the ability to make empowered decisions, understand the decisions that you're making, and feel like you can impact, and that healthcare isn't happening to you, that you are able to make decisions that impact your health.
I like that a lot, Michelle. So I'd be happy with that addition. Chunwei?
Yes, I agree.
Okay, thank you. And looking at the phrase that's there, primary measure of success should be the attainment of every individual resident to be satisfied in their opportunity to make and act on timely, well-informed health decisions for themselves, unimpeded by external forces of bias, location, or financial impediments to access. And I think there's been a couple of suggestions for changes in that. Possibility of, I think equity is implied by unimpeded by external forces of bias. Does that work? Another possible suggestion for change was shared decision-making. And I like the language that's there, but if someone would like to argue for shared decision-making rather than something like well-informed health decisions.
Michelle has her hand up.
I would just argue
Michelle, yeah.
plain language whenever possible. And I know that there's a consultant in Eastern Oregon that I've worked with in the past, and they have certified plain language specialists that can take documents like this and translate them so that average residents could actually understand what we're talking about. I think this is very specific and I like it, but I think it's pretty jargony, and I don't know if we took it on the street and asked people what we were talking about, if they would actually, if it would be very accessible.
That makes sense to me. I think, and I think we could approve this subject to running it by a plain language specialist. Katie and Jenny, do we have someone in the state organization who can review for plain language, or do we need to go outside?
I made a note to look into that and figure out if we do, and if we don't, then yeah, we'll look inside, and I can also talk to Michelle about her Eastern Oregon recommendation as well.
Okay. I would see, we've had a little discussion about population measures, and I would kind of see that that's a little bit, we're calling attention to the fact that it might be the operations committee who might need to look at what other measures the state uses and to agree, subject to full board approval, on what community measures we use. And I agree with Debbie that having some kind of community measure is important. I did read through article from Amy on alternate goals, but I don't know enough to choose one over another. So my recommendation would just be that we do need a community measure, and that we need to coordinate with other state agencies. Is that good enough?
I'm curious, Chunwei, if I guess, well, I'm directing my question to you, but I guess this is to the whole group here today. If we are proposing citizen juries as a way to implement our values and principles, could we go through a citizen jury process and then at the end of it, kind of based on that feedback around priority setting, decide on a population measure? Is that a process you've seen work, Chunwei?
Yes, that's exactly what citizen jury is for. In terms of health outcome measurement, because the choice of any health outcome measurement is subjective. And given it's subjective, it's often based on value. This is where citizen juries become very important. We want to derive the values based from the Oregonians that's considering all subgroups. And also, one of the advantage of citizen jury is we can decide when we select members what aspects, what characteristics of whether it's gender, age, ethnic group, region, etc. What kind of minority characteristic must be represented in the citizen jury?
So I'm hearing two things. I really like the suggestion that that we have kind of two bullets under this. One is a citizen jury or other means of community establishment in what should be measured. And the other is just that we need to study what other state agencies are using and at least what the differences are if we don't adopt the same ones. Janie, do you think that we can wordsmith that?
The definition under population measure to include those two components?
Yes.
Yeah.
And what I would propose, because we're changing some language and we have two members who aren't here, if we could just make the edits and just circulate it for approval prior to the board meeting.
Yes, yes.
Okay, so could we scroll down?
Before we continue, can I make a quick comment about measurement? So as we try to solicit the public values about what should be the health outcome measurement we want to prioritize, one measurement has been very popular in international comparison of national health system. Which again, we can propose that as just not the measurement, but one of the measurement we may suggest for the board, but also for the citizens jury to consider. That measurement is called deaths amenable to healthcare, meaning we want to minimize the deaths that can be prevented because such deaths either have a prevention or have a cure with the current technology. So that has been a very popular international comparison of how effective is the national healthcare system in promoting population health. And of course, that's not the only measurement, but that has been one of the very popular measurement, and which is, I would say, less controversial. And of course, we are concerning about equity. So we want to make sure that preventable deaths are prevented across all community, all groups.
Yes, I think that's one of the measures that I'm coming to believe should be adopted, among others. Thank you, Chun-Wei.
Could you repeat what that's called?
There are usually two or three synonym terms. One popular term is death amenable to healthcare.
Thank you.
In the board meeting, a suggestion was made that we add minimize harms from healthcare. I have no objection to adding that. It does, I think, might make people wonder what we're getting at specifically, but I don't object to it being there. Michelle, do you have any comment?
I don't object to it being there. I think it's a good inclusion. And I think that I'm curious if emphasizing regionally, linguistically, and culturally appropriate care, regionally available as well as linguistically and culturally appropriate care would fall under this. I think those are some of the ways in which I hear about harm in healthcare settings from community members.
Okay, thank you. And yes, for me, I wonder just a little bit about what's actionable to there. You know, I don't think our job is to be training doctors or disciplining for malpractice or you know, there's numbers of things that I think are a little bit outside our scope, but some things that that are in it. I have no objection to adding it.
I think that makes sense. I think under the current coordinated care organization model for Medicaid patients, for example, interpretation there's a lot of work that's been done on training and certifying more interpreters, especially in rural and frontier communities. And then also the reimbursement rates for interpretation services to make sure that that's accessible. So I think there are many ways of ensuring that minimized harms from healthcare is actionable outside of solely punitive approaches.
Okay. I see some changes here to the B part of that. And this is where I would have really expected that we would have, talked about citizen juries. I think there's two components to this. I mean, for me, this is a community-wide decision about priorities, fairness, rather than an individual and family or patient. I mean, this is more of a policy question than an individual care question. So I would have preferred to keep the might have taken the first sentence out and go to matters of defining fairness and how it is applied to distribution of direct, and I guess that should be of direct care, should be informed by the community itself, taking care to use a process that is inclusive and equitable. So I propose dropping the first sentence.
I agree with that. And I know we're using citizen jury as a concept, but I also, what I like about your proposal, Warren, is that, I think it makes clear that we're talking about all residents of Oregon and being inclusive. And I think the word citizen jury doesn't necessarily have that same connotation. So I really like that broad, you're
Okay.
right, beyond individuals and families.
Yes. You agree, Chun-Li?
Yeah, I also agree.
Thank you. We, I think, have already dealt with the title of number 3, and I don't see any other comments that we need to address in that section. So I guess.
Actually, one question. I thought we had talked about reducing cost sharing in the context of this number 3.
We did have last time we met, we talked a little bit about where are we falling short in the maximizing health, fair distribution, and cost sharing was mentioned as a something that's preventing people from getting that individual agency and satisfaction. So I think to me, it's kind of a level down. It's one of our actionable, how do we put this into operation? And so for me, we don't need to mention it here. If we believe these principles will get cost sharing out of the way because it impedes health. So you could argue more for it. That was my thought. John Wayne?
Yes, but I thought the legislation in 1089 already said explicitly no cost sharing.
I think that's true.
Okay. Katie, do we have any other comments to work through? Okay,
Nope.
thank you. Yeah. And now if we could go back to the slides and just see if there was anything that we missed. Okay, next slide. I think we've covered all of these. Yeah, people holler out if you see something that we've missed. I think we've covered these as well. Oh, the last one is something that has come up in other discussions. Some people really want to know, does that apply to smoking? How far does that go? And I don't think we've really addressed this, but it may be the matter for communities to help decide. Just one of the list of things to decide of if and by the way, I think I'm opposed to that, because when we start making judgments about other people and what they choose to do or not, it may be more trouble for us to keep track of who's supposed to be charged more or get less care than, I mean, it's just too much, adds too much complexity to the system. But I would like to ask you, Chun-Wei, in other countries, do they make exceptions for smokers, for instance, and treat them in some other way than regular people?
Not in country with universal health care. To treat them separately usually happen in commercial health insurance. But I just want to bring one interesting kind of controversy that was brought up briefly in around 2008, when Japan, with its universal health system, were debating about health care as a right and obligation. So the controversy part is obligation. And of course, that not just stirred up the debate in Japan, but around the world, at least in the academic world, whether we want to engage in that ethically contestable argument of health as an obligation. So the original debate in Japan that brought up in 2008 was the proponent of that is arguing, in a universal health system, the finance was collectively financed, and therefore individual has some level of obligation, not necessarily to keep healthy, but at least to follow some guidance. So initially in Japan, they were invoking, actually, that it was included in the Japan's national health insurance law, but they never implemented it, because it was stated in the Japan's national health insurance law that the citizens and beneficiaries of the national health insurance has an obligation to following guidance given by the clinician. And if the individual did not follow medical directives, they may be subject to suspension of the coverage. And that was in its legislation, but was never implemented. It was in 2008. Policymakers brought that up to see whether we want to implement that And that stirred up a lot of debate and controversy. And so the issue related to that last point is actually related to that broader issue. That is, in a collective finance health system, such as universal health system, besides healthcare as a right, do individuals also have an obligation to maintain health? And that touched upon an even broader issue of the societal determinant of health, because to what extent an individual have a control or responsible to his or her own health. So that is the core of the issue.
And I could see why that would be controversial. And in this day where medical science is always evolving, I had a physician who identified me as a non-cooperative patient for I'd done my own research, and I refused a drug that was within the year removed from the market and banned. So I'd like to see some leeway, but you know, how much? So that will make an interesting discussion as we get to it. So if we could go back up to, oh, Michelle.
Sounds like this, I mean, this is too complex to resolve today. I would just want to go on record and say I would oppose moving in that direction based on what I know today. Maybe I'll learn more later, but I think at minimum, it violates the Hippocratic Oath that medical practitioners take to refuse someone treatment because of a value judgment they have about a decision, a personal decision that that person has engaged in. And we already have charity care as a legal requirement for hospitals. If search and rescue doesn't deny services to someone because they were unprepared in the wilderness, like there's so many other aspects of our structures that say have decided that that is not a direction that we are prepared to go in. And so I just want to be clear on the record today that that's kind of where I'm coming from.
Thank you, Michelle. Excellently stated. So if we can go back up to recommendation 2.
Hey, Warren, if I could just make a clarification.
Oh.
I just went back and checked to be sure. It was the task force that recommended no cost sharing, but that wasn't written into Senate Bill 1089. So it's not a requirement of Senate Bill 1089. It was just a recommendation from the task force.
Thank you, Jenny.
Mm-hmm.
So I would say let's withhold our recommendation number 2, overarching principles, recommending adopt the following principles as further defined by the work group report. And we will just do the, Jenny, if you could do the edit, and then we'll just circulate that to make sure that everyone, including Debbie and Amy, have had a chance to approve that.
Yes.
And it looks to me like with plenty of time left, our work is done. And I've enjoyed participating with this group, and am pleased with the ideas that we're putting forth.
Can I ask one clarifying question before we end? In what we were just discussing around decisions adversely affecting health, should I remove that from our considerations or leave
No,
that as part of it?
That is, I think that if anything, maybe we could be clear that those are things that we're recommending that a citizen jury or similar means help to make that decision. I think it can stay there.
Okay. Okay.
So I guess we have no further meetings scheduled. And Jenny, if you could just review again the boilerplate about how to make public input.
Absolutely. And just to let everyone know, I will turn around these changes and send them out to all members of the work group, probably by the end of the day tomorrow. And for members of the public, just to remind you, as Warren suggested, if you would like to make public comment, please feel free to do so. You can do so by sending public comment, written comment, to the address on our website, which I believe Katie shares at the end of every meeting and the beginning, I think. Or you are more than welcome to attend the governance board meeting. The next meeting will be on July 18th from 9 a.m. until noon. At the end of every meeting, we do take live public comment. And so you can sign up and be there in person, or you can sign up and testify virtually on any of the work that we've done here today. And as always, if you have questions, please feel free to reach out to me or to Katie to ask any follow-up questions. Okay. Excellent.
Hey.
You will see our changes coming forth soon, and I appreciate all the attendance today. And thank you, Warren, very much for facilitating this work group and all the work that you've put in to help us get all of the materials ready for each meeting.
Thanks.
Okay. Michelle, stay safe.
Yes, by all means.
Yeah, stay safe, Michelle.
Thank you, everyone. Okay.